The chest tube portion of this lecture will be much shorter, probably about a half hour or so. Just going to go through and explain the different types of chest trauma that can occur and the different types of pneumothorax and chest tubes. So blunt trauma to the chest. So that's sudden compression or positive pressure inflicted to the chest wall. So the most common cause of blunt chest trauma are motor vehicle crashes, because think of how the chest, smashes into the steering wheel right in front of you. So that's kind of the most common, but it can be other things like falling off a bike and your chest hits the handlebars on your way down. Something that is a sudden compression or force against your chest. And when this occurs, you can end up with sternum and rib fractures, and you could possibly end up with multiple rib fractures as well, and we'll talk about that in a little bit. Barotraumas are also under blunt traumas. So barotraumas can actually occur as a result of very high PEEP. Right, so remember PEEP from mechanical ventilation. That's a lot of pressure that you're exerting into the intrathoracic cavity, and sometimes that can cause barotrauma and end up with a pneumothorax. Also injuries to the pleural, lungs, and digestive tract. Also all of the great vessels. Think of what is within your chest cavity. So you have your heart, you have all the great vessels like your aorta, your vena cavas. So when people have injuries to this area, it could potentially be really, really life-threatening, because if they injure any of those great vessels or the heart, etc., then they could have massive blood loss and basically exsanguinate and pass away from it. Patients that can occur with blunt trauma. So patients become hypoxic because there is some injury to the lung or to the ribs, some area of the airway. They can become hypovolemic because of, like I was just explaining, all the great vessels that are in the chest cavity. If they are ruptured or injured, then patients can bleed, have massive hemorrhage, and exsanguinate, so they become hypovolemic. And just talking about hypovolemia for a minute, how would you suspect, or what would make you suspect that someone were bleeding? What's like one of the first clinical manifestations that you see of someone who is, exsanguinating or hemorrhaging? So it's tachycardia. So a lot of times when people are bleeding profusely, they become very tachycardic, and that's oftentimes one of the first signs. Then patients can also get cardiac failure just because of injury to the heart. So they can end up with cardiac tamponade. Remember, that's like a fluid collection or blood collection around the heart within the pericardial sac. Remember, we talked about Beck's triad, the 3 Ds. So that's for cardiac tamponade, the distended neck veins, the distant heart sounds, and the dropping blood pressure. Those are the 3 classic symptoms, Beck's triad. And also just the increased intrathoracic pressure that can occur after these traumatic events can cause a poor venous return to the heart. So remember, we talked about venous return when we were talking about all that increased intrathoracic pressure with PEEP on mechanical ventilation. So it's kind of the same situation, just a different cause. So with all those problems that can occur, patients end up with impaired ventilation and perfusion. Nice to know information. I don't expect you to absolutely know all of this, but it's basically important to just gain a history of the traumatic event that occurred and try to hone in on your most important complications to evaluate for. And oftentimes that will be things like airway obstruction, a flail chest, or a massive hemothorax, or open pneumothorax, things like that, that you're trying to assess for something that is severely life-threatening. Your management will be oxygen, airway support, so ensuring that your patient has a patent airway. They may need intubation and vent support if it's severe enough. Reestablish fluid volume, so if they are hemorrhaging, then you're going to be giving them IV fluids. You're going to possibly be giving them blood transfusion, something to reestablish their fluid volume that's being lost. Reestablish negative interpleural pressure, so this would be like inserting your chest tube to alleviate the pressure and buildup that's occurring within the chest wall. Drain interpleural fluid if necessary, so again, chest tube. If it's a hemothorax that has occurred, then you're draining the blood that is accumulating in the chest cavity. And sternal and rib fractures, so pain, so that's going to be very painful. And you really want them to be able to cough and deep breathe to try to prevent atelectasis from occurring. So you want to be sure that they are comfortable enough to do so. So this is a complication of barotrauma because it occurs when there are multiple rib fractures. So with the blunt chest trauma, the ribs can either break just, singly, or they could end up with multiple. And the concern that we have when it's multiple is they will have multiple breaks. So it's basically like the ribs get shattered. So there's floating rib segments. And when this happens, patients become very sort of like restless. They are tachypnic. They have having trouble breathing. And when they breathe, you see something called paradoxical respirations. So I don't think I can play this video here in the PowerPoint as I am recording. I don't think it will record that as well. But basically, paradoxical respirations are when, normally you take a breath in and your chest rises. Well, say you had 5 ribs that were shattered on the right side. When you breathe in, your left side is going to expand and rise like it should, and the right side that has all the fractures is going to sink inward. So it's actually going to go downward. So it's opposite of what it should be doing with normal respiration. So if that's kind of hard for you to picture, I'd recommend just Googling it, paradoxical respirations, and there are YouTube videos that you can see what I'm trying to explain. So it's multiple rib fractures in one area, and when someone breathes in, the unaffected side rises, and the affected side sinks inward. Okay, so it kind of goes backwards. So complications of flail chest is retained airway secretions and atelectasis. Sometimes with flail chest and this blunt trauma that has occurred, sometimes patients can also develop like hematomas, pleural hematomas, and that would be of concern as well because it causes basically like a swelling in the lung tissue where the injury is. So that will affect somebody's ability to ventilate and breathe adequately. Management for flail chest is secretions, encouraging cough deep breathing if they are awake and stable enough. Humidified O2, so we give humidified O2 to help thin secretions, that way they are easier to excrete and remove. So when we have dry secretions, that's when we get concerned for mucus plugging, which I talked about that in the previous lecture. Pain control is huge, monitoring ABGs because you want to know how they're ventilating and how their acid-base balance is. Ventilatory support may be necessary in very severe cases, so that just simply means that they would require endotracheal intubation and mechanical ventilation. And the pulmonary contusion is that pulmonary hematoma that can develop in the lung tissue. So if that develops, these are the signs and symptoms that you would see listed here. And you want to monitor for shock. So we know our signs and symptoms of shock, right? So basically you become tachycardic, tachypnic, hypotensive, your body starts to kind of clamp down, so you get that cool skin, your pallor, okay? So that's just sort of your general signs and symptoms of shock. So there are 3 types: closed, open, and tension. Closed pneumothorax, or simple, is basically when the lung collapses within the pleural space. So it can be caused by surgery, or it can be caused by a disease, sometimes trauma. And some common causes would be people who have like chronic lung diseases and they have really frail lung tissue, like really fragile and not healthy lung tissue. And when they have lung tissue like that, it puts them at greater risk for the lung tissue to sort of burst or tear open. So where it says rupture of a bleb or a bronchopleural fistula, so that's like sometimes these patients with chronic lung diseases will have almost like these little like blisters basically on their lungs. And those can sometimes pop on their own, and when that happens, it can injure the lung, causing a closed pneumothorax or simple pneumothorax. Okay? I actually had a patient recently who was brought down to our ICU from one of the medical floors where I work, and he was a patient who had a long-term, like almost end-stage emphysema. So he was really severe COPD emphysema, and he was admitted to the medical floor with trouble breathing, and the nurse had gone in and done her assessment around 7 a.m. in the morning, first thing, and noticed that his eyes were a little bit puffy and he was having trouble breathing. He had to sit up on the side of the bed, in a tripod position because his breathing was so bad, and he needed 100% of oxygen on the non-rebreather. And eventually he came down to the ICU just because of how he was deteriorating so quickly. And by x-ray, we were unable to see if he had a pneumothorax, but he was acting like he was. All of his signs and symptoms were acting like he had a pneumothorax, because another thing that can occur with pneumothorax is that air from the, chest wall cavity and the lung cavity where your lung should be is escaping, and it gets underneath your skin. And that's called subcutaneous emphysema. Okay, so subcutaneous emphysema. And it also is called crepitus. So those two words mean the same thing. So subcutaneous emphysema and crepitus mean that there is air that is collecting underneath the skin. So with this patient who was having all this trouble, and we were feeling around on his chest and up on his shoulders, and you could feel all of his crepitus under his skin. So he had all this air collection that was occurring. And when you feel it, it feels almost like Rice Krispies underneath the skin. So it's kind of like little crackly bubbles under the skin when you palpate it. And sometimes patients can have it in just small areas. If they have a chest tube, it might collect around the insertion site of the chest tube, but this guy had it pretty much everywhere. And what we found out was that the puffiness that the nurse upstairs on the regular floor had noticed in the morning, that was actually crepitus. That was air that had traveled all the way up from his chest all the way up into his face and in his eyes, and they became so swollen with air that he couldn't even open them. So long story short, he was very critically ill. He ended up intubated with endotracheal tube and put on mechanical ventilation, and we were able to get him down for a chest CAT scan and found that he did indeed have a pneumothorax. So he had a closed pneumothorax, and emergently we brought him back to ICU, and the thoracic surgeon placed the chest tube to relieve all of that air that was building up in his chest cavity. So that's an example of someone who has really bad lung tissue, that their lung just kind of pops or bursts on its own because of how frail it is, and they end up with a spontaneous or closed pneumothorax, simple pneumothorax. So all your clinical manifestations are right there, all right? And I kind of just talked about some in my story. So hopefully that helps to picture what these patients can look like. Pneumothorax, or also called penetrating pneumothorax, this is when you have an opening through the chest wall that causes a pneumothorax. So this would be like your penetrating trauma. So that could be like a gunshot wound, a stab wound. This could even be something like a procedure like putting in a central line in the subclavian vein up below your clavicle. So your subclavian vein is right up by your clavicle, and when a physician's trying to get a central line put in there, central venous catheter, the lung is right below it. So if the patient moves or maybe coughs or something, the physician can accidentally rupture the lung or pop the lung because they have their needle so close to it. So thoracic procedures can also cause open pneumothorax, and that's because the needle has gone through the skin into the chest wall and created, that small little hole that ends up causing a pneumothorax. So other causes are blunt trauma. So if your rib fractures, were to break and stick out, cause a hole in the chest wall, diaphragmatic tears, and also barotrauma from mechanical ventilation. So your clinical manifestations, when you have an open pneumothorax, kind of one of the classic things is a sucking sound when they breathe in and out. So you can hear the air kind of escaping in and out through the hole in the chest wall. So it's called a sucking chest wound. And they also will have their pain, diminished or absent breath sounds, weak rapid pulse, anxiety, restlessness, difficulty breathing, altered ABGs. So when someone has a traumatic pneumothorax, it's really important to cease or stop the flow of air through the opening in the chest wall. So what you would do if this is someone coming in, from the field, and maybe it's a gunshot victim and they're coming in, they're going to have covered their gunshot wound with a gauze and taped on 3 sides. So this will help to prevent air from getting into the thoracic cavity. So it will allow for air to escape the intrathoracic cavity, so that way pressure will not build up, but it will help to prevent air from flowing into the thoracic cavity. So again, that's a dressing that you put over the site and, the chest wound, and you tape it on only 3 sides, so that way one side is open for air to escape out. Okay, so that's also called a tented dressing. Okay, so like a little tent. So it's only taped on 3 sides to allow air to escape out. Because if air cannot escape out, we will end up with a tension pneumothorax. Continued is also classified as hemothorax, so you can see here in the picture where blood accumulates. And then your tension pneumothorax. So tension pneumothorax occurs when air can get into the pleural space, but it cannot exit the pleural space. All right? So like I was explaining earlier, when you have a big penetrating chest wound, you can hear that sucking sound when patients breathe in and breathe out. With tension pneumothorax, they breathe in and get air pulled into their intrathoracic cavity and it gets stuck in there. So when air is getting trapped within the intrathoracic cavity, then you're going to start to have problems with too much pressure in the intrathoracic cavity. Okay, so it increases the tension that is within the intrathoracic cavity. When this occurs, it causes a shift in the trachea, in the heart, the great vessels. Everything starts to shift to the side that is unaffected. All right, so that, if that makes sense. So say you have a right-sided tension pneumothorax, okay, and air is getting into the right side of the pleural cavity but cannot get out. So with every breath you take in, more air is coming into that right side, more air is coming in, and getting stuck in there like a big balloon. You know, it's like blowing up bigger, bigger, bigger. All that air is collecting and pushes everything, like your trachea, your heart, great vessels, everything's going to shift away from the tension pneumothorax because it's like a big balloon pushing pressure, and it's pushing everything out of its way because that air has nowhere to escape. So this is an emergency because it can lead to decreased venous return of the heart, which would be then leading to decreased cardiac output, and impaired cardiac output means that the rest of your body is not being perfused adequately. So emergent situations, patients with tension pneumothorax, physicians can put in a large needle into the chest wall to kind of deflate all of that tension, or if you're, better with picturing things, like it's like a big balloon that's building up in there, all that pressure is getting bigger and bigger, and they put a big needle through the chest wall into that balloon, and it allows all that air to just squeak out and come out. You hear a big whoosh of air when that happens. So tension pneumothorax are very serious because of how they can put so much pressure on the heart and cause all of the mediastinal shifts. So pneumothorax treatment. The goal is to evacuate whether it be the air or the blood from the pleural space. So this means chest tube insertion. So I did, mention the tented dressing, so you can put the gauze with the petroleum, only tape on 3 sides to allow air to escape when you exhale. Your chest drainage systems. So there are 2 types listed here. This over here on the left is your water seal chest tubes. So the difference is that this over here on the right is your dry chest tube, okay? And the way that you can tell, how can you tell, is it a dry suction chest tube or a wet suction, wet seal chest tube, is by looking at the differences between the 2 collection chambers. So if you look here on the left side, you see chamber A is a clear column, right? You see this big open clear column. Has a little dotted line across it here. So that's where you'd fill your water, okay? Because this is a water suction, water seal chest tube. So you'd fill your water in this A chamber to whatever is prescribed by the physician. Most oftentimes, it's right to this dotted line, which is 20 centimeters, negative 20 centimeters. So this is how you control your suction when patients are hooked up to a chest tube. Over here, you can see the A chamber is much different. The dry suction chambers are a little dial. You can see this little dial here. It kind of looks like a clock. And this little orange piece here shows you how much suction you have. Again, most oftentimes it's probably going to be negative 20 centimeters of water. So they look a little bit different, and that's how you can tell which type it is. So the dry suction will have a little clock dial, and your wet suction is going to have a chamber for water to be in here and control your suction. Some other important things that you need to know is in the B chamber. So each one has a B chamber. You can see on each side here. That is your water seal chamber. And you can't really see any, maybe this is it right here. There's a tiny little ball that sits in the B chamber. It's a little white ball. And when the patient breathes and they inhale, the little ball will travel up the B chamber and then exhale, travel back down. So both situations, both in the wet section and the dry section, that little ball in the B chamber, the wet seal chamber, is going to float up and down with inspiration and expiration. And that's called titling. So titling can also be called fluctuation. So it means the same thing. So basically there's fluctuation in the B chamber or water seal chamber when the patient is breathing, and that's normal. That's what we want to see. One thing that we do not want to see is in this C chamber, which is still part of the water seal chamber. It's just a little square part of it at the bottom. You can see more clearly in the dry suction picture that the C chamber is filled to that little dotted line there with water. So this here, where that little white ball will kind of sit right here and go up and down, when it comes down, if there's an air leak within the system, within the chest drainage system or the chest tube itself, if there's an air leak, you're going to see continuous bubbling in C chamber, in the water seal chamber. You do not want to see continuous bubbling in these chambers, okay? You do not want to see it because that means there's an air leak within the system, and the system's not going to work properly if there's an air leak, okay? So this whole section here, B and C, is the water seal chamber. In the B chamber, you're going to see the fluctuation or titling when the patient's breathing. And in this C chamber, you're going to look for any bubbling. Sometimes you might get intermittent bubbling. That happens sometimes. It can be patient positioning, but it's when it's continuous or constant when we start to become concerned and want to let the physician know. Seal or wet suction, again, so you can kind of see in this picture here, the water in the A chamber is filled to the -20, and when you hook up your suction to that tube up top, this chamber, the water suction, wet suction chamber, will start to bubble, and that's normal. So you want the water suction chamber to bubble because that means your suction is working. What you do not want to bubble is your wet seal chamber. That's this one down here. So don't get those two confused. So this is A, your suction chamber, and C and B are your water seal chambers. Water seal chamber, you do not want bubbling. Okay? So this too, I don't know if I press on it, if you'd be able to see this in the recording or not, but I'll try, but it just shows you what the bubbling looks like. Alright, so it doesn't look like that's going to work. But again, you can Google this. So if you just Google, wet suction or water seal chest tube drainage systems, you'll be able to kind of see what I'm talking about. You can tell because of the little dial it has, so it looks like a little clock. When your suction is intact and working, this little orange piece below it in the E chamber that you can see, this little orange piece will sort of extend across this window. So that's how you know your suction is working and your suction is applied with these dry suctions. Because in the wet suction, you can see that A chamber bubbling up and down because your suction's making it all bubble. But with here, you just set your dial and then you look for this little orange bellow to fill out and expand this window. So that's how you know your suction is intact on the dry suction water chambers. So your management. So you always want to ensure that your chest tubes are patent and that they're connected securely. So your chest tube will oftentimes be clamped, the tubing itself will be clamped to the patient's bedding or something, so that way it doesn't sort of fall off the bed and pull on the chest tube. You always want it to be secured. Everything up at the chest, where the chest tube is inserted into the chest wall, that is sutured in place, and it has a big, sort of like stretchy tape dressing on it to hold it in place. You also want to assess the water seal chamber, right? So the water seal is that B and C chambers. Okay, you want to make sure that the water is at the correct level, and that has the little dotted line on that chamber. If you go back and look at the pictures in the water seal chamber, the water's filled to the 2 centimeter line, and you also want to be sure that your water is filled to the appropriate suction as well. So if you have a wet suction chamber, remember that A chamber is going to be full of water. You want it to be full to your prescribed amount of suction, which oftentimes is the negative 20 centimeters. All right. Monitor the characteristics of drainage. So you have the drainage chambers that are more towards the right side of the drainage systems, and there are oftentimes a couple of columns that can collect drainage from the chest wall. So if you have a simple or closed pneumothorax that's just simply air that you are removing from the chest wall, you're not going to see any drainage come out. But if you have a hemothorax, something that's more from trauma or, penetrating chest wound, something along those lines, then you'll be monitoring how much bloody secretions are coming out. And if you have a significant abrupt increase in your, output for someone who has a hemothorax, that would be something that you'd want to report to the licensed provider, because that could indicate that someone may be hemorrhaging or someone's becoming worse, that there's a problem happening. So that's why it's important to monitor your drainage and how much is coming out, to look for any changes in that data. Assess for the fluctuations or titling. So remember, that's in the water seal chamber, so chamber B. And with the fluctuations, the patient's going to breathe in and out. When they breathe in, that little ball will travel up the B chamber. And when they breathe out, it'll just fall right back down the B chamber. So that is normal. That means the chest tube's working normally. The chest tube system should always be kept below the patient's chest level. So when you're traveling with your patients, if you have to bring them down for a chest x-ray or whatever, or a test, you need to be sure that that chest tube system is not going to be plopped up on top of the bed next to the patient's chest. It needs to be below the patient's chest. So the drainage systems have these little hooks that will hook onto most bed systems in one way or another. So that way you can just hook it on the bed frame so it maintains below the level of the chest. Maintain appropriate fluid in the water seal and wet suction systems. Palpate the area around the chest tube insertion site for subcutaneous emphysema or crepitus. Remember, those two words mean the same thing. Subcutaneous emphysema or crepitus, that's the air that is accumulating under the skin. It feels like Rice Krispies or little crackly air bubbles when you palpate it. And you want to keep clamps at the bedside for emergencies. So oftentimes patients will have Kelly clamps, or what they're called, at the bedside in case something becomes dislodged. You can have your clamps there, so that way you don't end up causing a lot of air to go into the interthoracic cavity, causing tension. Okay, and that way you can use your clamps too if you need to assess for air leaks within the system, and you can kind of clamp off the tubing of the chest drainage system and note if there are any leaks in the system. Patient care, pain control, because chest tubes are uncomfortable. They're very large tubes, and they're put right in through the ribs, and when patients move or cough or deep breathe, it hurts them. So you want to be sure that their pain is under control so that they can cough and deep breathe. They can do their incentive spirometry, because if they're not doing those things, they could develop atelectasis and become worse. Repositioning them, so that kind of goes hand in hand with just the coughing, deep breathing, repositioning, sitting them upright, so more upright, the better for lung expansion, that sort of thing. And observe and immediately report any problems that could occur with the patient. So if you notice a change in their breathing pattern, if they're becoming more rapid to kypnic, that could indicate that there's a problem. Maybe they're developing, tension. Maybe the chest tube's not working adequately. So that's something that you want to pay attention to. Cyanosis would obviously be something that is a big problem. That would indicate that someone is hypoxic. Remember, that's a late sign of hypoxia. So if someone is hypoxic, something's happening there. We need to let a physician know, the licensed practitioner, that something is happening, that there's a change. Pressure in the chest. So if you notice any shifting of the trachea, so when patients have the tension pneumothorax, remember I talked about the midline shifts or mediastinal shifts where the trachea and the heart and everything starts to shift toward the unaffected side. If someone's developing any tension, you could possibly see that their trachea is sort of shifting or pushing to one side. That would be a big problem that would need to be immediately reported to a physician. Subcutaneous emphysema. So this is something that patients can have, and it's completely fine. You just monitor it to make sure it's not getting any worse. But it's something to be sure that the physician does know about. Hemorrhage we talked about, and significant changes in vital signs. You to see for visual people, so pneumothorax, again, kind of like I was saying earlier, it's like a balloon, and the balloon is popped. So air in the pleural cavity resulting in lung collapse, and here are all your causes. Your treatment's going to be your chest tube. You need to relieve whether it be the air or the blood that's in the chest cavity, and these are some of the signs and symptoms that you may see. So oftentimes they can be diagnosed by chest x-ray, but I know I told my story earlier that my patient that I had with that spontaneous pneumothorax from the floor, we couldn't even see his pneumothorax on chest x-ray, and it was mostly because he had so much subcutaneous emphysema that it was hard to see anything on x-ray. So you almost couldn't even see the structures of his heart on his x-ray because he had so much subcutaneous emphysema that just made him look like completely white out. So it looked very abnormal, but oftentimes with a chest x-ray you will be able to see that someone has a pneumothorax. So if you have any questions about chest tubes, I know that sometimes it's confusing, especially if you have not seen them, but at least you'll see a little bit of hands-on. You can play with the dry section and look at a wet section in sim, and hopefully that will help to piece things together. But if you have any questions or something's just not making sense to you, please just reach out to me, email me, and I'm more than happy to clarify whatever issue you're having or question you may have. And also, please remember to go on to e-learning and go to the forum section and complete the assignment for this lecture so that I can give you your attendance as present once you have submitted your answers to the questions, and also respond to 2 other students with your professional opinion or other things that you think of that also pertain to the question, or point out some great points that other students have made. So it's kind of just like support each other, have a little bit of a conversation about this, and hopefully learn from one another. All right, so that assignment will be due by Sunday night at midnight. All right, so that's submitting one short response from yourself, answering questions, and please answer to other students as well. Is assuming care of a patient who just arrived via ambulance with blunt chest trauma. Which disorders would the nurse assess for first? Select all. So think back to the very beginning of the lecture where you want to sort of assess those essential life-threatening situations first. So in these options here, it would be C as in cat, flail chest, and E as in elephant, airway obstruction. So those are two from this list that would be your highest priority that you'd want to check for first. So I know I mentioned hemothorax earlier, but that was severe hemothorax. So someone who just has a regular hemothorax, someone who is not exsanguinating or hemorrhaging, would not be the priority here. So that is the difference. I don't think. But when caring for a patient with a chest tube, you see this in the chest drainage system during inspiration. You know that it indicates, so in this, if you were able to play it, you would see bubbling. So if you saw bubbling in this small square chamber down here, what would that mean? So it would mean an air leak. Remember, continuous bubbling in the water seal chamber is an air leak. The immediate goal of managing a traumatic pneumothorax is what? It's C. C as in cat. Ceasing the flow of air through the chest wall. Remember, if you have an open chest wound, you want to cover the chest wound with a, petroleum gauze, tape it on 3 sides. It's called a tented dressing, and this allows for air to escape from the intrathoracic cavity when patients exhale, but when they inhale, the air cannot be brought in. So you're stopping the flow of air into the chest cavity. Okay?